Welcome to the Intimate Marriage Podcast, where I teach educated, successful couples how to have incredible, passionate relationships so that you can stop compromising and start feeling fully alive in your relationship. I'm Alexandra Stockwell, aka the Intimacy Doctor. I'm a physician, a relationship and intimacy coach, and I'm an intimate marriage expert. My husband and I have been married for 26 years. We have 4 children and full professional lives, and we've created an amazing marriage. I've shown hundreds of couples how to do so as well. So if you want to deepen your understanding of your own relationship and learn to access new heights of emotional, sensual, and erotic intimacy, you're in the right place. I will show you how. Now, let's dive in. I'm really excited to welcome Dr. Rachel Rubin to the podcast. Let me tell you who she is. Although you may already know, you may have heard her on NPR. I guess when this drops, it'll have been a month or two, or read about her in the Washington Post. This is the kind of doctor we want to be serving because she just keeps going bigger, reaching more people, getting her message out. And I'm really grateful that you're here today to share it with listeners of the Intimate Marriage Podcast. I am going to say more about you, but I just want to say welcome first.
Oh my gosh, I'm just so grateful. That's more than enough to, make me proud. And just thank you for having me. I know we've been trying to get this scheduled, and I'm just so thrilled to be here.
Okay, well, me too. And if you haven't heard it before, remember this name, Dr. Rachel Rubin. She is a board-certified urologist and sexual medicine specialist. Her practice is in Washington, D.C., and quite frankly, if I specifically needed your services, I would go to Washington, D.C. to be your patient because Dr. Rubin is a clinician, researcher, and vocal educator in the field of sexual medicine, and she is one of extremely few people, the only one that I myself am familiar with, who's actually properly fellowship trained in both female medicine, sexual medicine, and male sexual medicine. And that combo, we want that in our bedrooms. I think we also want that in our physicians because how it all works together is so essential. And while all of this is true, the main reason that I wanted to talk with you is because you are juicy, your comments and education is practical, and you're so scientific. And that is just an unusual combination. There's so many people in the sexual, I don't know about medicine, but let's just say the sexual arena who are profoundly not scientific. And any training, which was very little, but any training that I have ever received as a physician, it was like we were talking about different species of worms. It was like so dry. It's like, do the people understand that they're talking about orgasms and ejaculatory fluids and, like double-blind case review, whatever. And it's like hard to believe that research when it's conveyed in such a flat way. It's like the body language and the verbal communication are so cognitively dissonant. And I just think you bring it all together in this inspiring leadership package. So again, welcome. And the place that I'd like to start is the word biopsychosocial. That is a term that is not used so commonly in regular vernacular, but any doctor has heard that. And most doctors have heard it as they roll their eyes, like biopsychosocial, like what a joke, because what really matters in medicine is biology. And then someone like me coming through medical school, like I love the psychosocial. It's so alive for me, but it always seemed really separate from the bio. I think the bio is incredibly important, but it's rarely integrated with the psychosocial elements of being a patient and pursuing health and achieving health. But my impression is that you really genuinely blend the bio, the psycho, and the social in the way that sexual medicine really demands to be successful anyway.
Yeah, I mean, I think it is, we're trying, right? We're doing our best, and you can't practice sexual medicine without a biopsychosocial approach, right? I can't just give someone erectile dysfunction medications and not ask them about their partner or what's going on in their lives or what their questions are, how they feel about all of this. And I'm a very sensitive person with a lot of empathy, and I can't spend only 10 minutes with people. It literally kills me that anyone can only spend 10 minutes with people and even think, what a joke, even think that they can get to know you and know who you are and where you come from and what you care about. And the point of sexual medicine is quality of life. My job as a doctor is to try to optimize and enhance your quality of life any way that I can. And if I don't get to know you, if I don't ask you the right questions, if I don't ask you what your goals are, I can't help you do that. And I tend to help through that biopsychosocial way, because if I understand what you need, well, then I can help guide you. Who's the right sex therapist or sex educator, sex counselor or coach that you need to work with? What are the right medications that we can tinker with? What are the right hormones that we can play with? And what is the education that we need to do to get you to understand why this will help optimize your quality of life? And I will tell you, it is not age that is the predictor of good sex and happy relationships. And I know I'm speaking to the choir here. I actually just yesterday had a whole clinic full of 78, 85-year-olds who are having tons of sex, right? Life goals. They're having tons of sex because it is the quality of the pleasure that they are having. It is the intimacy that they continue to have. That is the predictor, in my experience of doing this for a long time, is the predictor is the joy, the pleasure, the happiness, the closeness. That is the predictor of long, good sexual relationships that continue on. And if you don't look at that from the biopsychosocial approach, we're never going to succeed.
I'm thinking it would be good to just step back. Maybe you've just answered it, but how do you define sexual medicine? Like, it's a term that feels good, but for someone who's listening, they know when to go to the cardiologist. They know when to go to the gastroenterologist. When do we seek out a sexual medicine doctor, and what really is that field?
Yeah, so sexual medicine is a budding, growing field that is not, again, there's one fellowship in the country that acknowledges women's sexual health. We have about 27 for men's sexual health. So it's much easier to find.
Okay, whoa. Where is that fellowship? Let's start there.
That's in San Diego with my mentor, Dr. Erwin Goldstein, and I hope to have a fellowship one day. That is my next life goal that I want to accomplish in the next year, if I say it out loud. We don't have enough, right? We don't have fellowships that are really focused on women's sexual health. The fellowship that I did with Dr. Goldstein was really focused in everybody, right? It's all genders. And so we got about 27 for men. But we have lots of people. So I'm the education chair of a large organization called ISWISH, the International Society for the Study of Women's Sexual Health. So while there are not many fellowships in women's sexual health, we have about 1,000 members who care about this deeply. And they look at it from, there are some clinicians, there are some mental health providers and physical therapists and basic scientists. So it's not all doctors, but it's really a multidisciplinary group that focuses on this. So you can find a sexual medicine provider to help you. But really, we do four things. Well, no matter what gender we take care of, we do four things. We deal with issues of arousal, desire, orgasm, and pain, right? So cardiologists, they do a lot of things. Sexual medicine doctors, we deal with arousal, desire, orgasm, and pain. And there's a lot of overlap there. And so if you have any condition where you feel that it has affected your desire, arousal, orgasm, or pain, we are the right people to see. And you can invest in someone who really, really understands what's going on and can take your medical history and really help understand how that is affecting your sexual health. Because we'd like to think about sex as magic. Oh, sex is magic. It's all unicorns and rainbows. It's not magic. It's network, right? It's physiology. It's the autonomic nervous system. It's sympathetic, parasympathetic. It's reflexes. It's hormones. It's horny teenagers. It's biology. And of course it's the unicorns and rainbows and the psychosocial and the touchy-feely, but that's a part of the biology as well. And so it is really actually a complex form of medicine. Maybe that's why nobody wants to do it. But that's what makes it actually very fun. Is I like to think of myself as Dr. Rachel Rubin, sex detective, right? I have to take a complex, that's going to be my first TV show, right? I have to take a complex issue, right? And try to make it make sense for you and your partner. You and your partner, if you have a partner, right? It's so fun.
Okay, so what I would love to do, if I don't know how you handle it in terms of sharing client stories or making them up, either way is good as long as it's relevant. Will you teach us something about how you approach desire, how you approach arousal, and how you approach orgasm? Because I'm guessing, like, when someone comes to you, they're not going to distinguish which of those necessarily is the issue, or maybe they will.
Yeah, so the key in any sexual medicine consult is time, spending time with people, and a really good history, right? The physical exam is very, very important because your body tells a story as well. Your tissue tells a story. Where the pain is tells a story. Where the pain isn't tells a story. But first and foremost, the history is everything. And my history isn't just, when we went to med school, right? It was, if you were lucky, you got about a 20-minute lecture on how to take a sexual history. And it was, do you smoke? Do you drink? Do you do drugs? Do you have sex? Men, women, or both? And that's it. Like, sex is a vice. It goes in do you drink? Do you smoke? Do you have sex? Because that's not good for you. None of those things are good for you, which is insane because everybody has sex with themselves, with other people. That's how humans are made. Like, it's a really strange concept, right? So you have to take a really good sexual history. So what does that mean? It means people tell me their story uninterrupted for quite a long time of, I am here today because, right? What brought you to see a sex doctor, right? I just tell me your story. Then I ask about their medical history, their surgical history, what medications they take. I ask them about what they do for work, what they do for fun. I ask them about family history of problems. And then I get into the nitty gritty. It's only then, and that's a long time that goes by. And then I get into the nitty gritty and I go step by step. Tell me about your libido, and I describe it for them if they need help. Tell me about your orgasm. Can you orgasm? Do you have any complaints about orgasm? Has anyone ever asked you if you can have an orgasm? I ask them about their arousal, the lubrication, the engorgement, the erections, the quality. What happens? When do they work? Do they work, do your erections, do you get morning erections? Do they work when you're by yourself and they not work with your partner? I'll even ask people about their masturbation techniques. Nobody asks about that because it matters, right? I see men all the time where they say, I can't have an orgasm inside my partner, my female partner. Well, how do you masturbate? Well, I have to masturbate in this very specific position and this very specific way, rubbing up against it is not really congruent to like having sex. So if you don't ask those questions, you'll miss it, right? You'll miss the story. I ask, of course, about cultural issues and religious issues and trauma issues, right? Trauma is the huge elephant in the room. So many people, and trauma is just, you have to be comfortable sharing it with me. And I find patients, it takes time sometimes, right? So I keep the door open to some of those issues. And so I ask about back problems and urinary symptoms. And I ask about childhood. Like, I ask about questions that no doctor really ever asks about. And I can only do that by taking time with people. So a consult with me, if you're in my office, is if you're going to get examined, it's an hour and a half, right? And even that I find sometimes when you come with 30 years of pelvic pain is not enough time, right? And so it really have to understand the way medicine currently works with these 10-minute visits and this $40 copay and this, it does not work for these types of problems. And so I can't, and in fact, I couldn't get a job when I got out of fellowship at a big university because they said, ooh, you won't make us enough money. What you do doesn't get reimbursed by insurance companies, so we can't hire you. What you do is a little weird, Dr. Rubin. So I had to kind of be forced to kind of be an entrepreneur and do my own thing, which thank goodness, has been lovely. Does that make sense? Like, in terms of what you were asking about, how we approach these issues?
It definitely does. And pain, pelvic pain, pain during sex, pain anticipating sex is really a massive issue. And I'm just going to park it. It deserves attention. It's just not how I'm going to manage this interview. And I'd love to hear, so if you identify that desire is where someone is low, I don't even know how you describe it actually when you get super medical. Do you just call it low desire, or is there a fancy Latin term?
Yeah, so there's all sorts of fancy stuff, of course. We love low desire. So low desire is very common, right? About 40% of women will say they have low desire. And a lot of men have low desire too, actually. We treat both. We actually have more tools in our toolbox for women than we do men. And I use a lot of those tools for my male patients. And so low desire is not a medical problem unless you are bothered by it, right? If you come to me and say, I have low desire, but Rubin, I couldn't care less, I'm here for another problem, it's not an issue. But if a patient tells me I am bothered by this, so 40% of women will say we have low desire, but actually only 10% will say it bothers them. And so I can't go after the 40, I have to go after the 10%, right, who actually say it bothers them. That's plenty of people, let me tell you. And so the medical term that we use is hypoactive sexual desire disorder, or HSDD. And HSDD is a medical condition, no matter what. There's a lot of politics here, and we could talk politics all day long. I'm in DC. But HSDD is when you are bothered by your low desire. And it's not from your partner being a jerk. It's not from, oh, well, I have great sex on vacation, but I'm, or it's not from a medicine. Like it's really I used to want, and I want to want. I don't want anymore, but I want to want. I want to want. So many people say that is, I want to be interested, right? I want, and it's understanding a little bit desire, right? Many people identify as having responsive desire, right? If someone initiates, okay, I don't really want to do this, but then my partner's initiating, okay, orgasms feel good, I'm going to get into this. Oh, actually it's like exercise. Nobody wants to exercise, but you start doing it, you feel good, your heart rate's getting up. Nobody regrets exercise and saying that was terrible, I shouldn't have done that. Of course, you enjoy it. So that's responsive desire, which is normal, right? So so it's getting to educate people on what is normal, but also if they want to want more, we have tools in our toolbox, and we have a biopsychosocial toolbox, meaning sex therapist, your podcast, right? Education materials, erotica, there's all sorts of things out there, but we also have medications that can help. And we also know that medications can harm people. So antidepressants, while wonderful for depression for some people, can also have side effects of low libido and delayed orgasm. So we actually have medicines that can do the opposite, that can kind of boost dopamine in your brain, that can make you a little bit interested. And they don't work in everybody, but they work in about 60% of people, right, who take these medications. And so we play with testosterone for men and women for desire, and that can work quite well. And so it's getting to know people, meeting them where they are, and then giving them the toolbox to say, here's the options. We can tinker with the toolbox. And if I don't get to know you and what you want and meet you where you are, then it's hard to know what to recommend. But if in 10 minutes, give me a break, people. It's just, there's no way.
Okay. And will you talk a little bit about arousal and how you think about that and how you serve people with arousal?
Yeah. So arousal is on the male side is erectile dysfunction. And so if the penis is not getting hard and rigid, it's very common, right? 50% of 50-year-olds, 60% of 60-year-olds. There's no shame in the erectile dysfunction game. This is very common. All of your golf buddies have this. It's just none of you are talking about it, right? And so you have to understand, actually, I find men are very comfortable with me because they talk to their often wives, right? If we're talking heterosexual, they're talking to their wives if they have erectile dysfunction, not their golf buddies. So when men come into my office, I'm confident, I'm comfortable, I know more about the penis than they do. And so they'll tell me anything, right? They feel very comfortable. And so erectile dysfunction is actually really important for you to go to your doctor, and a knowledgeable doctor, because it is a marker for cardiovascular disease. It probably is for women as well. We just don't have as much research. And so we have to really take it seriously. And we have lots of tools to help with improving erections. In order to have a healthy penis or clitoris, you have to have healthy muscles, arteries, and nerves, right? It's not magic and unicorns. It's muscles, arteries, and nerves. And if you have high blood pressure or diabetes or any spine condition or any hormone issue or menopause, that can affect muscles, arteries, and nerves, right? And so we take that knowledge and we say, how do we make those muscles, arteries, and nerves work even better so you can arouse? On the female side, arousal is engorgement, lubrication, right? Clitoral swelling, which can really change with menopause, right? So you can get dryness, you can get pain, you don't feel that same orgasm. Just the other day, I had a woman come in with her wife, and she said, I lost my orgasm, Dr. Rubin. I'm in incredible distress. I want my orgasm back. This is not fair. And she had experienced menopause where the tissue no longer had the hormones that it so desperately wanted, like a thirsty plant. It just wanted to be watered and have some nutrients. And it's not just add a little lubricant, like you actually have to give back those local hormones, which are very safe, very effective. And if you follow me on social media, I talk about it nonstop. And so we provided her with this treatment, and she came back just this week, and she said, I'm back, baby. She said, I'm back, baby. My orgasm is back. She was so happy. Oh my God. Those are the best, right? Those calls are the best. I didn't do that much for her, but it was enough for her tissue to respond the way that it used to respond, and her orgasm was back. The other thing with arousal is devices are the best. And as a doctor, I am prescribing you all to go out and get devices to play with in the bedroom. This is doctor's orders. You must go and get high-end, wonderful tools to have more fun in the bedroom, right? And people need that permission from their doctor to say, oh, this is actually doctor's ordered. Penises love devices, clitorises love devices, everybody loves devices. And so the high-end nature of devices these days is so wonderful. And you can really think of it as adult playtime, right? This is your toolbox. This is your playground. And don't do it the same way every time. You don't go on the same vacation every time. You don't go to the same restaurant every time. Mix it up a little bit.
Do you have a particular website or websites that you recommend that we could put the links in if someone's listening? Because just going and looking for high-end devices, it's hard to follow that as an instruction, even if it is doctor's orders.
It is hard, right? So, or it's not hard. That's the pun, I guess. There's many websites out there, many incredible companies. I like, as a urologist, we often use Promescent, which is a delay spray for premature ejaculation. Promescent. We can put that in the show notes. They have a nice curated, I help them curate the devices. So they have wonderful devices for men and women and couples. And so what's nice about it is it really helps get people started to say, well, this is for everybody. So you can really understand the different and see what kind is out there. And then that can help you explore to different companies, different products, and things like that. We were also recently, this is so cool, there was a British newspaper that talked about this wonderful company called Mystery Vibe. It's a British-based company that designs devices for health reasons. So they do research. So they've done studies now on arousal and erectile dysfunction, and they create devices for, these pelvic conditions in mind, whether it's erectile dysfunction, delayed orgasm, pelvic pain, and the company's called Mystery Vibe. And there was a whole feature in a British newspaper about devices and vibrators. And I was quoted, I said, my God, when you're quoted in a British newspaper about devices, you think of the Queen clutching her pearls. Like, we've come a long way, baby. Like, this is very exciting.
Okay, fantastic. So we'll make sure to have show notes, the links in the show notes for that. Both of those companies. Does Mystery Vibe ship internationally?
Oh, yeah, it's great.
Okay, excellent. So I want to swerve completely because I ask every guest on the show this question based on my own conviction that intimate relationships are the ultimate vehicle for personal growth. And I know that we haven't really talked about any of your personal psychosocial at all, but I've seen you have beautiful daughters because I've seen them online. And I guess the elegant thing would have been to ask you ahead of time, but are you with their father?
Yes, I am happily married.
Okay, good. I really, that's on me. I should have clarified that ahead of time. But anyway, what I would love to know is what you've learned about yourself as a result of being married to your husband.
What I've learned about myself, I've learned that I'm incredibly grateful that I was born in the generation that I was born in. The men being raised today, at least in my circles, are pilots on this mission. And I genuinely believe I have a partner who is my co-pilot. And so there is no women's role and man's role and you do this and you do that. Now there's things we each like doing, right? Like I can't get that man to fold laundry for anything. So I do, I do the laundry, but he goes the grocery shopping. He does the cooking. He raises the children, maybe a little even more than I do. It's very much a co-pilot situation. And he is incredibly supportive and proud of, the work that I do and, has been with me since, intern year and really had gone through, knew what he was getting himself into with medicine and how hard it is to date and be married to a surgeon. It is not easy, especially, someone who,
it takes a lot of self-respect on his part.
Well, and it's really wonderful to have that and then to also, support each other and support, what each other does. And he is not, in medicine, but he is in a field that's sort of medicine adjacent. And so there's really an understanding. And I used to joke when I would go on dates with people and I would talk about, I'm going to be a surgeon. If they were like, ooh, gross blood, can't hear about that. I was like, okay, this is not going to go anywhere. Like this is not, we're not meant to be, right? So someone who can, actually, this is a great story. When I was an intern, I was, doing overnights at a hospital in general surgery. And I get a call. I just met my future husband and we were going to go on, he was a paramedic at the time and I was a young intern and we were going to go on a breakfast date because we were both doing overnights. And we just started dating and I get a call from the head surgeon and I answer the phone and my shift was about to be over. And he said, what size gloves do you wear? I said, 6.5. He said, get your butt down to the operating room. Somebody got a large mag light stuck up their rectum, right? Talk about sexual health, right? He got a big thing stuck up his rectum. We need you to come get it out. I said, oh my goodness, I'll be right there. That sounds like a fun case. And I called my, future husband. I said, hey, I gotta cancel our date because a guy got a big flashlight stuck up his rectum. And without skipping a beat, he said, man, if I had a nickel for every time a girl broke a date with me for that reason. And I said, okay, he's a good egg. I'm excited to go out with this guy again. So I love that story because, the part, they have to truly know you and your personality and what you do and just love you for that. And that, I think that I've learned a lot about watching, I've learned a lot about myself through that.
I really love that you shared that because my experience, we don't really talk about this particularly, but our personal experiences influence how we practice medicine in profound ways. And the science is the science, but I think one of the places where this is most striking for me, because I had my first child while I was in the third year of medical school, is I watched particularly OBGYNs who would really believe in patients and support them to birth vaginally. And then if one of those OBGYNs herself had her first child via C-section, I saw that after that, her ability to, like when she recommended the C-section and when she encouraged the woman to really keep trying and believe in her, it got shortened by her own experience. So I'm not saying that's all anecdotal. I don't know if anyone's ever studied that, but I definitely have seen how our personal experiences profoundly influence how we practice medicine in a way we don't like to think happens because medical practice is so scientific. But there's something in what you've just shared about being so encouraged and supported and believed in, and how he believes in you and your mission that just shines through and makes so much sense given the ever increasing impact you're having. It's just, thank you for sharing that. And thank you for sharing everything else. Any last words that you want to share with listeners?
No, just grateful to be here. If people want to follow along, we have a great newsletter that they can sign up for at rachelrubinmd.com. My social media is very loud. I would say Instagram and Twitter threads and Facebook. It's at Dr. Rachel Rubin, which hopefully we'll link to in the show notes. But really just so grateful to be here and, thankful for what you're doing to help couples, because I think, the patient is the couple. And I think what we do to one really can impact what happens to the other. One of my favorite things is to have never met sometimes partners and to know that I've improved their sex lives dramatically is really one of my favorite things about my job. Is I had someone just the other day who said, my husband is so grateful, because, actually now that I'm the one with the higher libido, and he wants to come in as a patient because of what you've been able to help me with. And those stories, that is just the most fun thing.
I really love that. And I thoroughly second following you on social media. If this is a conversation, as you listen, you're like totally comfortable and tracking with everything, well, then get more on Dr. Rubin's social media. But if this is all a first foray into these topics, it's just lurking on your social media is always available, and just the right amount of stimulating and inspiring. So I highly encourage everyone, whatever your platform is, to follow Dr. Rachel Rubin there. And thank you again so very much.